Hello, everyone, and welcome to today's webinar, TripleTree Thought Leadership Session. Before we get started, I'd like to go over a few items so that you get the most out of today's session. You've joined the presentation listening using your computer speaker system by default. If you would prefer to join over the telephone, just select telephone in the audio pane and the dial-in information will be displayed. You will have the opportunity to submit text questions to today's panelists by typing your questions into the questions pane of your control panel. You may send in your questions at any time during the presentation. We will address questions throughout today's discussion. I would now like to introduce Michael Carroll. Michael?
Good morning and welcome to Market Insights Live. My name is Michael Carroll and I'm the Chief Marketing Officer at TripleTree. Today's session is focused on the growing adoption and demand for behavioral health services. We're fortunate to have a great group of panelists representing a diverse set of activities across the behavioral health ecosystem. A reminder that the views and opinions expressed in today's session are those of our participants and do not necessarily reflect the official policy or position of TripleTree and its affiliates. To begin today's conversation, I'd like to introduce my colleague, John Hill, who will provide some context about the market dynamics around behavioral health. John, I'll pass things over to you.
Thank you, Michael, and good morning. Thanks everyone for joining us today on a topic that undoubtedly has impacted each of us either directly or indirectly in our lifetime. My name is Jonathan Hill. I'm a managing director at TripleTree, and I help lead our client engagements across healthcare services. Before jumping into the panel discussion today, I'm going to take a few minutes to share some of our contemporary observations of the behavioral health market. Over the last decade, the awareness and demand for behavioral health has increased significantly. Much of that has been driven by the reduction in the stigma that has surrounded mental health for far too long, in addition to improved access to care from regulatory changes such as the Mental Health Parity Act and ACA. With behavioral health spending expected to reach about $280 billion this year, we now sit at a very critical inflection point. COVID-19 has drastically changed the way we live, the way we interact with one another, and has significantly impacted our economy. Unfortunately, this new and social economic environment is triggering underlying behavioral health conditions. To highlight the severity of this situation, I want to share a few interesting and alarming statistics with you. During economic downturns, there's historically been a 60% increase in drug use during economic downturns. Similarly, for every 1% increase in unemployment, there's a corresponding 17% increase in alcoholism. And finally, and probably most sadly, during economic downturns, the suicide rate increases by 6.5%. So said simply and bluntly, we need access to high quality behavioral health care now more than ever. Lucy, next slide, please. As a result of these underlying trends, we've seen a very rapid acceleration of the M&A activity across behavioral health, both from strategic acquirers and private equity investors. Specifically, since 2015, we've accounted for over 370 transactions that have been completed in the behavioral health arena. One area that's received a disproportionate share of interest is autism. Over the last 2 years, since 2018, there's been over 28 new private equity platforms highlighting the large and growing market opportunity to provide ABA therapy to the 1 in 59 children estimated to have autism spectrum disorder. Another deal I want to highlight was completed earlier this year in March, just before the COVID lockdown took place, was TPG's investment in LifeStance Health. LifeStance Health is a rapidly growing provider of outpatient behavioral health services. And given the increase in the general mental health conditions triggered by COVID, as I discussed before, we absolutely anticipate increased interest and investment activity in the outpatient general mental health arena. Lucy, next slide, please. In addition to investments in healthcare service organizations, we've also seen a tremendous increase and the volume of transactions focused on technology solutions within behavioral health, including more than $1.5 billion of financing and acquisition capital and more than 25 transactions over the past 3 years. Many of these transactions have been focused on providing better access to care in a virtual environment, such as Bessemer's investment in Ginger, and also other technology and software solutions that enhance clinical, operational, and financial capabilities of the underlying behavioral health providers, such as Lightyear Capital's investment in therapy grants. Again, in a new world that is all things virtual, again, we anticipate additional M&A activity and additional private equity investment in technologies and solutions that support behavioral health. Thanks again for joining us today. We will, on this panel discussion, we will discuss these topics and more. With that, I will turn it over to my colleague, Jeff Jones, who will introduce the panelists and kick off the discussion. Thank you.
Thank you, John. I'm Jeff Jones with TripleTree, and thank you everyone for joining us today. We have a diverse group of leaders from across the behavioral health spectrum today that cover autism, substance abuse treatments, eating disorders, as well as a national payer that sees services from across the behavioral health spectrum. We encourage, as was mentioned earlier, everyone to participate in questions, through your question panel on your site here. Please insert those questions, and we'll try to get to as many of those as we can throughout the session. Let me introduce the panel. Dr. Stephen Friedhoff, Senior Vice President and Chief of Clinical Operations and Products at Anthem. Dr. Friedhoff is a seasoned executive with more than 20 years experience in clinical and administrative leadership. Steve previously held the role of Chief Clinical Officer at Anthem and is focused on driving high-quality, cost-effective clinical programs that are improving health outcomes and helping address some of the nation's most pressing healthcare challenges. Dr. Jillian Lampert, Chief Strategy Officer for the Emily Program. The Emily Program is a comprehensive eating disorder treatment program with multiple locations across the country. Dr. Lampert is also the founder of the Red C, the national association representing eating disorder treatment providers across the country. She is a longstanding advocate for the eating disorder community through her involvement with the Eating Disorder Coalition and the organization With All. Mike Miller, CEO of Caravel Autism Health. Mike joined Caravel in 2014 as CEO and successfully grown the company from 3 locations in Wisconsin to more than 35 locations across 5 states, all while focused on delivering best-in-class care to those in need. Mike has more than 20 years experience leading and working with growing businesses. And Carter Payne, CEO of Axial Healthcare. Axial offers a comprehensive risk-to-recovery substance use management platform, partnering with health plans for end-to-end network and care optimization. Carter joined Axial in 2019 as CEO and has spent his entire career working with companies that challenge the status quo and strive to improve health outcomes. Prior to joining Axial, Carter co-founded and served as president and COO of NaviHealth, a Nashville-based care transitions and post-acute management business. Welcome, everyone. Thank you very much. So let's jump in. Our first topic centers around demand and the growth that John spoke about across behavioral health. We're going to get to COVID, so trust me, we'll definitely touch on COVID. But before we get there, I'd love to hear from each of you about the past decade and the tremendous growth that we've seen. And Mike, maybe we could start with you in autism. One of the statistics that John highlighted was 1 in 59 individuals, the prevalence of autism today, and which is a staggering statistic. But also what is staggering is that number is about double what it was, 10 years ago. Can you speak for a moment just on some of the key drivers of growth throughout autism over the last decade?
Sure, happy to do that. The incidence rate that John referenced has increased significantly, and there's two factors. One is the identification rate has gone up significantly. So access to diagnosis is greater, although not to where it needs to be. And so autism is being diagnosed today at a much greater rate because of the access to those experts. The second thing is that the incidence rate is relatively even across geography. So you may see very slight differences in a state or a region, but very, very slight. And what that means is that whether you're in a rural community, a suburban community, an urban community, the incidence rate of autism is significant. And I think what you're beginning to see is an identification of autism outside of some of the urban areas with access to the best healthcare. I think that what that means for our sector are a number of things, but that the infrastructure is building to identify and ultimately treat autism, but it's still very, very early. And I think that certainly advocacy groups like Autism Speaks have raised awareness. Parents are aware of the potential of autism. Pediatricians are more aware of the potential of autism. And they're starting to have those conversations at an earlier age, which is really important to the identification overall and ultimately the path to best treatment.
Jillian, shifting to eating disorders, maybe just talk for a minute about how you've seen treatment evolve and the space evolve over the last decade.
Yeah, absolutely. I think we've seen a decrease in stigma, sort of similar to what Mike was saying around autism, and an increase of awareness. Half of all Americans say that they know somebody with an eating disorder, so it's more commonly discussed. People are more comfortable discussing eating disorders, but there are still a fair number of barriers to treatment. While the stigma decrease has helped, the increase in our knowledge around eating disorders as a brain-based biological illness, all the genetic and brain research has certainly contributed to people understanding more about eating disorders and moving us away from it being sort of a fault to being an illness. But there's still barriers to accessing care. We're doing well, better with awareness. We still have room to grow in screening, that we really need primary care providers and mental health providers to be screening for eating disorders to make sure that we're actually catching people who have eating disorders. And then the availability of treatment is still an issue. That the market has changed over the last 10 years in terms of more treatment availability, but there's still an incredible space for treatment availability. We know that about 30% of people with an eating disorder get care. So there's an enormous amount of people who are just not getting care. And we continue to see that evolve, hopefully, as we're able to expand treatment and offer more treatment options across the country and more geographies. But I think it's all set in the backdrop of eating disorders have the second highest mortality rate of any mental health diagnosis, anything in the behavioral space. And so we really need to bring treatment to folks so that we can decrease those mortality rates and get people access to the care that they need.
Absolutely. Carter, shifting to substance abuse, from your perspective, obviously the opioid crisis has been in the headlines for many years. From your vantage point, as you think about the current state of the opioid crisis and treatment protocols to address substance use disorder, how have those changed over the last decade?
Yeah, so I think first, we have made significant strides as a country against the opiate epidemic. Obviously, with COVID, we kind of have the perfect storm brewing right now. Last year, this time we were celebrating the first decline in opioid-related overdoses in over 2 decades. This summer, when we got 2019 data back, we saw a slight uptick again, and now we have this perfect storm. But as a country, we have made significant strides. I think MAT has played a large role in this. Certainly much more awareness and acceptance of MAT as the gold standard of care. But there's still barriers that exist. Jillian highlighted barriers. There are definitely barriers around MAT. Inpatient residential treatment centers, still only about 30% offer MAT for OUD members. And though X-waiver physicians have increased, the utilization of that X waiver has been pretty low amongst PCPs and pain management specialists. Rural access continues to be a challenge. And last, and Jillian hit this, and this is just shocking in 2020, stigma still exists for health plan members or for patients using MAT. Back to the progress we've made, we work with health plans, and so we have a bunch of data around the usage of MAT. And one metric we track is what we call conversion. And this is the newly diagnosed OUD members, how many of them are actually getting MAT treatment. And we've seen this number rise from around 20% a few years ago to upwards of 40% on average for the health plans that we work with. Adherence still remains the issue, and just starting MAT is not enough. I mean, you have to have adherent MAT to really see those drops in utilization, overdoses, inpatient admissions, et cetera. And so, I think we are seeing a rise in adoption and awareness. We work with MAT clinics across all the states that we work in. They're tremendous partners, and we see this kind of new age MAT clinic that really understands the value of holistic treatment, meeting the members' behavioral and social needs at the same time. And we have bi-directional referrals to those MAT clinics, really so they can get in our care navigation and peer recovery support programs to ensure adherence. But I think overall, I think we have a lot to be proud of on the strides we made against the opiate epidemic. Just worried about this perfect storm brewing right now.
Absolutely, and obviously a lot of common themes across you and Mike and Jillian as well, and education and stigma and lots of barriers. Steve, maybe turn to you for the payer perspective. And as you think about mental health, maybe just kind of a little bit of a step back, but as you think about mental health relative to physical health, what is that relationship like? How do you think through that relationship, and how has that perspective evolved over the years?
Sure, thank you. Well, certainly our goal, and certainly my goal, has been to take a very whole person approach to health, including physical and behavioral across all of our lines of business, except potentially where some Medicaid states still carve out all or part of the behavioral health benefit. Unfortunately, that has been decreasing over the years. Our own behavioral health benefit has been managed in-house rather than through a carve-out or a vendor for as long as I've been with the organization, with really a great deal of focus on behavioral physical integration. So I'm a primary care physician by background, and really the inability to separate behavioral and physical from overall well-being is pretty much ingrained in my DNA. And in fact, I think it may be even worth highlighting some of the experiences, some of the trends that we've seen over the last couple of months, really highlight, I think, that connection, at the same time highlighting some of the disconnects in healthcare in general. So for example, if you look back around March and April, we saw a pretty significant dip in admissions, but with a major return to pre-COVID levels. And that was in behavioral health as well as being true in physical health as well. For outpatient, though, what was kind of interesting was we saw a very brief dip in those services, followed by a very rapid increase that ultimately reached a materially higher baseline, even higher than pre-COVID, and really continues to do so. And the vast majority, not surprisingly, is being driven by telehealth. And that's in contrast to physical health, where we saw a similar trend in inpatient, but a sustained decrease in outpatient utilization. And while telehealth made up for about a third of lost PCP visits and a much smaller portion of specialist visits, the net reduction in outpatient physical health was significant, whereas behavioral health actually did increase over that period and continues to be increased to this day. States did lift some requirements, but in many cases, outpatient care for behavioral and physical is really not managed in terms of office visits. So I wouldn't really see that as a contributor to those kinds of trends. Another interesting point is that for behavioral health, we saw a pretty significant increase in first-time users, as opposed to an increase in the number of services per user, pretty consistent with some of the earlier comments. And that's not surprising, given what the country has gone through during the pandemic in terms of fear, isolation, loneliness, job loss, and potentially loss of loved ones as well. And very, very similar to some of Carter's comments, we have seen an increase in the utilization of substance use disorder treatment, including MAT. But what we haven't seen is an increase in opioid prescriptions, which is certainly concerning for more recreational and street drug use. And in terms of a couple of areas, I'd love to see greater uptake, and I know that there's more discussion on that later. Certainly telehealth, we'll talk more about that in a bit, I'm sure. Digital enablement, while there's certainly no substitute for the human touch, more of the digital tools that enable a day-to-day personalized approach to coaching and self-management that augment the human sort of behind the machine, and figuring out where these tools best fit is, I think, something to see a lot of acceleration of. And we'll also talk a little bit more about quality in a couple of minutes. I think that's behavioral health has been one of the toughest nuts to crack there in terms of value-based care.
Absolutely. Well, just so let's pause on COVID for a moment. Would love to, obviously it's disrupted not only lives for your patients, it's obviously disrupted, you know, the way that each of your businesses is able to care for your patients and your members. Jillian, maybe to get input from you first, maybe just speak for a second on how the pandemic has impacted your patients and also how that's, you know, from an operational perspective, impacted the way that you are able to care for them.
Yeah, absolutely. I think that the pandemic is really fueled for people with eating disorders. You know, eating disorders are an illness of isolation. And so when the whole country became much more isolated, we saw a rise in demand. And so that's been coupled with the need to stay safe and have people be able to get treatment in their homes. So just like everybody else, you know, at the Emily program, we flipped from in-person services for hundreds of people a day to telehealth services for hundreds of people a day in the matter of 3 days, which was really impressive and reassuring that we could do it. And we had the groundwork laid for telehealth services, thank goodness. And I think that to Steve's points, the technology is really an enabler. It's not a substitution. It's the enablement of the human connection through a different way of being. And so I think that's really allowed us to bring treatment to people who otherwise couldn't access care, which I think is a really fascinating side effect of COVID, that we've been able to reach people who couldn't drive very, far enough. It was too far of a drive to get to treatment, or they couldn't have someplace to stay, or they weren't able to access care. So from an ability to access, it's been a really impressive change. And that sense of how do we keep people connected, because technology is not quite the same. And so how in a high acuity illness do we make sure that we're doing things like medical monitoring sufficiently and psychiatric monitoring, nutritional monitoring, while at the same time we can now come into your home and see what your kitchen looks like, what your refrigerator looks like, what your living situation looks like. So technology, I think, has really been an interesting piece of this whole pandemic and brought us a lot of opportunities that we need to think about going forward. And it's also brought a lot of people needing care. To Steve's point of the first time people accessing services, it's been a really incredible timing of all of the ingredients that go into eating disorders. For most people have really exacerbated during the pandemic. So thank goodness for telehealth, and it's a great opportunity for us to continue to evolve and improve so that we can really shape this for a go forward basis, not just a pandemic mindset.
Yes, absolutely. Carter, from your perspective, obviously we've heard a lot about the impact from substance use disorder as we've gone through the last 6+ months. How has that manifested itself in your clients and their patients, and some of the tools that they've been able to pull on? Some, group therapy, IOP, there are some areas that are harder to navigate, than others, but, what are some of the ways that you've seen adaptation and substance abuse over the last, this past year?
Yeah, for sure. Well, Steve hit on it early on. We did see a drop in inpatient behavioral admissions during COVID, a big drop on the residential treatment side. We developed a new product last year that we launched this year in a couple of markets, including with Anthem in Tennessee, where our recovery management services were meeting members at residential treatment facilities and MAT clinics and getting warm face-to-face handoffs. Obviously, that was thrown out the window right away when COVID hit. And so we had to quickly adopt to using tele and video and relying on our partners for those warm handoffs, just not face-to-face. I think you've seen loosened restrictions in this area. All the MAT clinics are now using tele treatment services. And what I think you see is that you've accelerated adoption of tele. And you've also probably accelerated adoption of some digital therapeutics as well. I do think that, that acceleration of adoption is a good thing, but it's never going to apply to all the patients that have SUD. I mean, the human element is still very, very important. One thing that we've just been surprised by is that most of these members, certainly with SUD that we manage, really want to rely on text more than anything. Tele certainly works, but text is how they like to communicate. And so that's, one of the, I think, surprises that we've seen. This is not necessarily COVID related, but we partner with Aunt Bertha as well. And that's just been a great database that we've been able to access a bunch of SDOH resources that members need who are dealing with SUD. And not surprisingly, over half of our Aunt Bertha searches are around housing. Continues to be a massive issue for SUD members. So overall, I mean, I think technology adoption's been the good part of COVID. It's never going to apply to all members.
And Mike, as you think about autism, obviously some very unique challenges in caring for your patients. You know, maybe really kind of more of an operational question. How is, as you've gone through the last 6 months and tackled COVID in your various markets, what has that meant for the specific centers and your, as you've worked with your families?
So we've gone through cycles as most providers have, and the first cycle we went through was in April, where we actually suspended in-person treatment for about 4 weeks and went to pure telehealth. That created some of the same drivers that Jillian and Carter referenced, which is the need for quick adoption, the need for the development of best practices very quickly. And we spent a lot of time on that in working with other providers in our industry. Some industry associations came together and developed some very good practices that ultimately, I think, have served our entire autism treatment community very well. That worked for a short period of time. It worked while we were suspended. We were gathering PPE. We were developing new protocols for in-person treatment. Once we resumed in-person treatment, we have continued telehealth, but on a more limited basis for specific circumstances where there could be an infection in the family home or something like that. We've also continued it, though, more broadly in parent training, which is a really important part of our treatment that has often not had the utilization that it needs. And telehealth is ripe for that. We've also used it to provide more supervision to clinicians when having multiple clinicians with a client was not the right thing to do from a COVID standpoint. So those practices, I do believe, I think will persist long-term in our sector. I think it's also worth noting that the relationships between payers and providers, I think, have strengthened during the COVID crisis. The payers did really respond very quickly to the emergency, authorized telehealth in places it wasn't authorized before. And then the last thing I'll mention is it's really allowed us to gather a tremendous amount of research about the effectiveness of telehealth. Our field of healthcare, applied behavior analysis, is evidence-based when practiced in the most effective way. And the evidence around telehealth was much less significant than it was around in-person treatment. So I think that'll serve us very, very well going forward.
And Steve, a number of panelists have mentioned the impact of telehealth. Obviously, there are some things that have been changed or altered or loosened, opened up, during this period. How have you thought about, some of these changes, from the payer perspective? And are these things that are temporary and kind of one-off, or are there some that may have more of a lasting effect?
I think to a large extent, the impact of telehealth on behavioral health is probably here to stay. I think it's something that accelerated a trend that was already taking off. And to a large extent, it probably enabled a lot of providers, especially in behavioral health, to make that leap, really because they had to, just economically at that point. So even as people return to physical health, their PCP offices, for the most part, we're still seeing about 2/3 of the services in behavioral health being offered via telehealth. What's interesting is we've done some focus groups with both patients and providers, including in the behavioral health space, and we heard some pretty consistent themes around, it's working, but it's clunky, and there's interest in, more seamless, app-free approaches to using telehealth. What we've also heard, interestingly, from providers is sort of a split reaction to what it's like to be interacting with a patient in their home. On the one hand, we often heard that patients seemed more apt to be feeling comfortable, revealing things maybe they would have had more of a challenge revealing in a more controlled setting in the provider's offices. So that was a positive. On the concern side was that, especially in individuals who lived in smaller homes that, there was some concern about, oh, is somebody next door hearing me? Are the walls too thin? So there was a little bit of that back and forth. But one of the things that we're doing right now, because of a lot of the feedback that we received, is we're beta testing a low or potentially no cost telehealth platform that we can actually potentially provide to both physical health and behavioral health providers that are in value-based relationships. And they're actually being beta tested right now with both PCPs and behavioral health providers. And so far, we're getting pretty positive feedback about ease of use. So hopefully, things like this will provide not only value add to some of these providers in a value-based relationship, but it also gives us the ability to, or enhanced ability to share potential outcomes or data in support of that value-based agreement and hopefully impact overall quality in the process.
That's great. Well, tremendous silver lining as you see some of these encouraging advancements and accelerations as we've gone through COVID. I see John has popped up on the screen, which means we may have a question from the audience.
Yeah, thank you, Jeff and Steve. That was a great segue into the question that we're getting from the audience here. This discussion around the adoption of telehealth and using different forms of communication, whether that be chatting, etc. People are asking a lot of questions around the use of technology, but also the types of data that you all as payers and also providers are trying to capture and share with one another. So I think it'd be interesting for the audience, and Steve, maybe you could start giving your most recent comment there with regards to data capture and outcomes measurement. Give the payer's perspective on the type of data they'd like to see from the various behavioral health providers, and then Mike, Carter, and Jillian perhaps can respond from a provider perspective as well.
No, certainly. So, data access has always been a real challenge. I mean, it's very, very limited what you can pull out of claims data. It's just inadequate, particularly for behavioral health care. Patient-reported outcomes would certainly be the ideal, but one, you've got to have the connection to an electronic health record to adequately capture this information, and two, it's got to be in a format that you can extract from more of a free text field. One of the places we've been exploring is more measured-based care for outpatient care. In other words, utilizing longitudinal tracking of self-reported measures such as the PHQ-9 or GAD-7 or similar to measure patient-reported progress. And our initial focus with a partner in this regard has been on depression and anxiety, even before we're able to make these kind of connections. And what's interesting is you start to actually see some early positive results, suggesting that even measuring the outcome seems to accelerate some of the some improvement, which is really not surprising. That first step, you've got to measure it before you can even start to consider making changes to improve it. But I think one of the things that potentially some of the digital and the tools, if we can get them into patients' hands, give us enhanced ability to collect and track some of this information potentially on a very frequent basis. Patients reporting how they're doing on a given day, how they're feeling, and what it can really do is enable us to better tailor interventions, whether as a provider, as a case manager, whatever the case may be, based on real-time feedback and really meeting the patient where they are in terms of readiness to change.
Got it. Mike, maybe start with you in terms of outcomes, data, and kind of your approach to the collection of information.
Yes, and this is very timely for us. We spent a tremendous amount of time and resources on this over the last 12 months. One thing I would point out about the autism spectrum is that it is more challenging to demonstrate outcomes because each child is unique and each child starts from a different place. And that's where there's been tremendous investment on our part, is to identify how we can find standard measures of progress across children, and so that we can create cohorts and we can study them in that manner as one approach. But we've really attacked this from three angles. One of which is we've developed a qualities of effective treatment standard tool, 27-point checklist of all the things that we think need to be there in an effective high-quality ABA program. And we do twice annual assessments of each program on those 27 points. So we've got clinicians who are not involved in the treatment day-to-day doing that assessment. That information is then uploaded into our database. And it really provides some very interesting training opportunities and quality improvement opportunities. The second two are really related more to outcomes. The second major element is we use standardized psychological testing. We now do that annually, so that at the beginning of treatment and then annually, we're using psychological testing to test the progress of the child. And that's really separate from what the clinicians that are working with the child are doing. So that's a psychologist that performs that testing as opposed to the BCBA who's working on treatment. And then the third thing is really where we spent the most time over the last 12 months, which is finding ways to gather data in the moment, in the home, on what's happening each day with the course of treatment. We have over 1,000 clients, and today we're gathering 100,000 data points each day on the progress of a child. And we're then able to aggregate that data in a proprietary database, and we are measuring the progress of that child relative to the program that's been designed for the child in order to progress. So there's a lot of work still to do here, and we are just on the forefront of beginning to share that with payers and get their reactions to that. But for us, it's been really about investment in the process and investment in the technology over the last 12 months.
That's fantastic progress. Jillian, as you think about eating disorders and data capture and the outcomes and the key outcomes that you're sharing with payers, how does that work with the Only program?
Yeah, so the field of eating disorders pre-COVID had really coalesced around a common set of measures that the field was aspiring for everybody to collect, and I think COVID derailed that for some people, but we took it as an opportunity to continue our growth in that area. So we had an outcome measurement system established that was electronic, that was tablet based. So when we saw you in person, we gave you the tablet, you filled it out every time you came in, and you gave us back the tablet. When we shifted to telehealth, obviously we weren't seeing you to give you the tablet, so we were able to flip that fairly easily to be able to send the link over email. That has a great benefit, except of course it relies on people checking their email and filling it out. So we've continued to evolve our outcome measurement approach. At the same time, we are building an app. So we took this opportunity to dive into technology even more deeply and are creating our own app that will go along with Treatment at the Emily program that will allow us, similar to what Mike was saying, for those thousands of pieces of data to be collected across our 6,000 clients every day, that will really give an individualized report on how that client is doing, as well as the standardized outcome measures. So we measure things like eating disorder symptoms, obviously, also quality of life, which turns out to be a huge indicator in most behavioral health, right? But particularly with eating disorders, we find that to be critical. And then anxiety and depression, the same things that we're all probably very interested in measuring. So if we can measure those 4 areas, every 90 days, we know where you are with your eating disorder, we know where you are with your anxiety, your depression, your quality of life, and then we are able to add in these day-to-day measures that not only the clinicians can see, but our UR team can see. So in those conversations with the payer, we can be giving real time, like, oh, you know what, today this is what this person said happened earlier this week. We're really looking forward to being able to really deepen that conversation. So our app launch is soon. We're very excited about that. But I think it's offered us a great opportunity to take it much more quickly than we probably would have otherwise. And I think is really in a way that will demonstrate not only us as leaders in the field, but also hopefully bring the field into a place where we know we can do it. That I think we thought probably we could do it, but this has really given us the opportunity to demonstrate we can, and we should expect it of ourselves.
That's great. Carter, I want to shift a little bit into quality, and a lot of these topics obviously are very intertwined as we're talking about outcomes, and but specifically in substance use, you think about outcomes and the transition as we're seeing across healthcare from more fee-for-service oriented payment systems into more value-based care. How does that play out in substance use, and also how does that then translate into payments for the services that you're providing and your clients are providing?
Yeah. So I think we're starting to see a movement towards value-based arrangements. I do think if you canvassed all the treatment providers out there, from inpatient treatment facilities to IOP to MAT, they would say, yes, payers are starting to talk about value-based arrangements, rewarding us for quality, but they may only have a couple of contracts with payers that have those elements. I think, they're slightly frustrated in the move. I think first and foremost, when you think of MAT, just getting into network with payers, I think historically has been a bit of a struggle. And now, the push is to go to a value-based arrangement. I think Steve hit on this earlier, but I do think payers are not looking at this as something I just carve out and try to push providers on lowest price and utilization pounding anymore. I think they really realize the ROI on strong quality behavioral health services. But I think what we expect to see ultimately is these MAT clinics, or even some of the inpatient facilities serving almost like a recovery home, and taking full, potentially capitated risk on members that they're managing. I mean, on the Medicaid side, the prevalence of SUD is just so high now. I mean, we've seen it as high as over 15% in some of our Medicaid plans, and really kind of low around 8-9%. So these members are driving 2-3x cost, and if they get reliable, high quality, both behavioral and treatment care, there's a strong opportunity to drive those costs down. And so, I expect the movement to start to occur pretty soon, but I don't think it's where providers want to be quite yet.
Got it. And Steve, one of the things Carter mentioned was in conversations with payers and becoming parts of networks that payers have in their various communities. How do you think about network development in behavioral health, and what are some of the key criteria as you think about building out a network in a specific market around some of these specific categories?
Sure. Well, yeah, I think some of that is actually in evolution, and it's being accelerated by everything we've been talking about, right? I think that in general, providing access to care, having the right geo-distribution of providers has always been critical. But I think what's even more important over time becomes, or not over time, but right out of the gate is, having the right types of providers. Just because you have X number of behavioral health providers in a given geography doesn't necessarily mean you've got the right ones that individuals need, whether it's related to eating disorders, autism treatment, PTSD, whatever the case may be. You've got to have the right providers there. I think the second component of it certainly is everything we've been talking about the last couple of minutes related to quality. And I sort of view, and I think a lot of us view, sort of a spectrum we've moved across in quality and behavioral health that really started with more process measures. Some of the early ones that we did with, say, residential treatment for eating disorders were more around, what's the program description, the education, the licensure, the training, availability, the types of therapies being utilized in terms of CBT, interpersonal therapy, right? And then moving to more outcomes measures, but outcomes measures that I guess that a plan can also measure around things like, not just length of stay, but what's the readmission rate? What are we seeing in terms of weekly weight gain, quality of life measures, depression measures? And again, a lot of them are things that we can't necessarily get out of claims data. We can get it by utilization review, but ideally in a future state, we would get it through much, much better data sharing. I think that the same could be said for, even in the autism and the ABA space. We've been working with some of our network providers around, we know that the average duration, for example, for ABA, at least in our network, is about 28 months. And some of the questions that we've asked back and forth with our providers is, well, where are these patients 6 months after they potentially stop seeing a provider? Are they back in treatment? If they're back in treatment, are they back with the same or with another provider? And trying to identify, are there other surrogate markers of quality and outcomes, where we may not have real good measures, especially when the long-term outcomes with ABA may be pretty lagged over time. So I think for us, a lot of it is trying to do this in collaboration with network providers rather than being draconian. We really want to make it a collaborative effort as it relates to value-based care.
Got it. And Jillian, as picking up on the value-based care theme, there's a wide spectrum of severity in eating disorders, and just being able to address across that full spectrum is so critical. If you could touch on that, and also just about the value-based care opportunity. Is there an opportunity for more risk-oriented arrangements with the eating disorder providers?
Yeah, absolutely. I think the field, in large part, much of the field evolved to sort of start at one level of care and only offer that level of care and then transition to some community provider. We didn't start that way at the Emily program. We've always grown from the ground up and added higher levels of care. So we have a bit of a different perspective than a lot of the other eating disorder treatment programs. And I think that kind of perspective is the one that's required for a value-based thinking, that if you really can help somebody through the entire course of their eating disorder in a way that they can access that care because it's close to their home, it's convenient, it fits into their lifestyle, it can ebb and flow as their severity ebbs and flows. I think that's where you really have the opportunity. If you have to, get on a plane, go to another state, get one level of care, come back home, get another provider, there's so many data collection opportunities that can be missed. There's a lot of pieces in that continuity that are just lacking. So we really believe strongly in you have to have the continuum of care from outpatient to IOP to PHP to 24-hour care in order to take care of people wherever their eating disorder brings them and then be able to follow them through. So I think that's, I think the Emily program is uniquely positioned to be able to do that, but I think it's critical to be able to offer a value-based conversation to say, we can collect the outcomes at intake and then we can collect them through the course of the 2 years or more somebody's in care because they're in care within the same system. So we've had some really good initial conversations with payers that are exactly as Steve was saying, not just the readmission rates or the cost measures we started with, but really how is somebody doing over time, and to the same sort of piece that Mike's talking about with autism, that people with eating disorders come in different places. They don't all come in at the same place or in the same level of severity, that we really have to be able to individualize the care and then measure that particular patient's progress against where they started and where they're going. But you can only do that if you have the whole course of care within your purview. So I think that really is a critical element of the value-based arrangements.
Absolutely. Mike, quick question for you, and then John, well, I'll turn to you for a question from the audience. But Mike, as we think about quality, services for a child with autism is obviously very unique and very personalized, as you have mentioned. How do you take that quality and then ramp it up as you continue to expand from a couple of locations to multiple locations across many states? The maintaining quality as you scale has got to be an incredible challenge.
It is, and it's something that we, like most providers, wouldn't want to compromise on it in any way. There's a few things that we've really focused on. So one is team development. So that is our existing team continuing to develop that base of clinicians. And over the last 12 months, over 50% of our most senior clinicians, our BCBAs, have been developed from within. So they've risen up through the ranks, they've been mentored and developed. So that's critically important, because if you're developing people from within, they know how you want care to be delivered. We do hire from the outside and do focus on that, and then training becomes critically important. Training is critically important for the existing team. It's critically important for those that you hire. And we train on a set of best practices. So we have a team of a half a dozen of our most senior clinicians, 15 years plus experience, either psychologists, BCBADs, BCBAs, who don't have caseloads. All they do is focus on our process, they focus on our training, and they focus on continuing to develop best practices. So that's why we were able to develop telehealth best practices in such a short period of time. And then the last thing I'll mention is those best practices have to become workflow. And you have to have teams of clinicians across, in our case, 5 states, some in homes, some in centers, following the same workflow. And it's really our investment in technology that has enabled that, so that a treatment plan gets written in a template, and the template has all the key elements. Once the treatment plan is written, the programs get developed from that treatment plan, and they follow a workflow that now exists on an iPad with every one of our clinicians, and they follow that workflow and they gather the data from that workflow. And with that, you get the standardization that you need. I don't want to by any means say that the treatment is precisely the same, because the interaction with the child has to be customized in order to really engage them in the program. But if we're following the major elements of the best practice, we can scale that and get that standardization and quality across the entire footprint.
That's great to hear. John, what do we got from the audience?
Yeah, thank you. And Mike, this is a good segue into the questions. You think about scaling the business in a multi-site model. The question we're getting from the audience is related to geography. And across behavioral health, we see different models of care of home and community-based settings versus destination models. And it also plays into, again, on what attributes of a specific geography do you need to help build that scale and density in markets over time. So perhaps the group could respond with some perspectives on how geography plays into the delivery model and the business model as you go forward.
Mike, you want to pick that up?
Sure. There's two ways that we think about geography and what you alluded to, John. So we provide both center-based treatment and home-based treatment. And the reason we do that is there's different points in a child's treatment and development in which there are superior elements of each. With that, it also fits into a strong belief that we have in being densely focused on our markets, deeply committed to the markets that we're in. So to Stephen's point about networks and what's the best network, we want to be well connected to the pediatricians in the communities we serve, well connected to the colleges and universities that train our clinicians, well connected to parents and community groups. And then we create a dense network where there are many points of access. And then those points of access can vary in the home or in the center with whatever the client needs the most. So I think that is certainly our opinion, the superior model in terms of how we're operating in our geographies. But I will also point out that that's not easy to achieve. Like that requires significant investment, and in a field of healthcare in which I think we're 20 to 30% built out in terms of the amount of infrastructure to serve the needs that exist. So there's tremendous needs that need to be built in those communities in models like that.
And Carter, there's an element of state regulatory regimes, particularly as it relates to MAT and other areas within substance use. But how does that extra layer kind of play into the geographic considerations of delivering care?
Yeah, I mean, so two of the health plans we work with are in Tennessee, and they have a very progressive Medicaid agency here, TennCare. Under the leadership of their chief medical officer, Victor Wu, they have really pushed MAT network adequacy, and then they've come in and pushed network quality as well. And I think the plans have responded really well with innovative approaches to bring those providers in. And so, access is not as big an issue as we've seen historically, still is on the rural side. And we've worked with some of our health plan partners on bringing tele-access where there's no X-waiver physicians or no MAT clinics.
Got it. And Steve, you guys obviously operate across coast to coast, in a number of different states. Are there models? Are there strategy? Are there pilots? Are there different differences between states in the way that they've approached behavioral care in general that are helping see results and potentially could be lessons learned for other regimes?
Well, I guess there's a couple of ways to look at that. I mean, certainly from the Medicaid perspective, there's a significant amount of regulation there. Some of it, frankly, very forward thinking and pushing payers and the broader provider community to think differently about how we integrate physical, behavioral, and other social needs. I think a lot of that is also true even outside of Medicaid in the commercial environment. But at the end of the day, healthcare is inherently a very, very local phenomenon, and it is crucial to be building out local provider relationships, relationships with local social organizations. You really can't address a lot of these needs without addressing social determinants. We haven't really talked a whole lot about that today, but particularly in Medicaid, where you see an incredible emphasis over the last couple of years, and I suspect you'll see even more and more of it, post-COVID, around everything from supportive housing. I mean, clearly, if someone is in recovery, you're not going to get very far if they don't have a roof over their heads, right? I mean, there's some really basic fundamental needs that need to be met before you can take it to that next level. But even things like educational support, addressing food insecurity, increased support for transportation services beyond just emergency, even routine non-emergency transportation, and respite care for caregivers when you start thinking even more broadly. These are, I think, some of the things that we're finding a lot of our state Medicaid agencies pushing. And again, it's different from state to state, but I think collectively you're even seeing a lot of best practice sharing between the states. And I think collectively, will be helping all of us, raise the votes over the time.
Absolutely. And Jillian, we can end with you. We've got a few minutes left here. Your impressions of differences and challenges, with geography and how you're delivering care.
Yeah, I would definitely agree with what Steve said about healthcare ultimately being local, and I think you have to think regional for areas that are less densely populated. That where are the regional health centers that people are used to going, and thinking about that from your geography is not just the market you're in, but what are the surrounding areas. And I think it's critical to think about that, because I think COVID has showed us that if you can't get on a plane and you have to get on a plane to go to treatment, what are you going to do? Or if you have to drive long distance, what will you do? And I think the other piece that I think we need to keep thinking about is the cross-state line licensure questions that many of us in behavioral health have run up against, and many of the states have been exceptional in terms of executive orders to allow cross-state licensure and cross-state practice. But that's, I think, one of the next things in our next chapter of how do we offer care across state lines in a more seamless way. We have had people who have to drive their car across the state line and sit in a parking lot in their car to get telehealth in this state instead of the one they live in. That's just wrong, right? That's not how we should be expecting people to get care. But our regulations, which make a lot of sense in a world without something like a pandemic, that's where we were. And so I think there's an opportunity for us as a healthcare organization in states to be thinking about how do we really expand geography outside of the state lines, and think about our workforce development in that way, think about our access for care that way. But I do think it's ultimately, at the end of the day, it's local or at least regional, where people get their care, and they have to have trust in the places they're getting their care in their hometowns or nearby.
Absolutely. Well, unfortunately, we could go on for hours. We go on for days, really, on these various topics. But I really appreciate you guys carving out the time. Thank you to everyone who has tuned in here. Really timely discussion. So thank you, Steve, Jillian, Carter, Mike, all for joining us, and appreciate the discussion. Michael Carroll, hand it back over to you.
Thanks, Jeff, and thanks to everyone for participating today. That concludes today's Market Insights Live. Our next session, titled It Takes a Village, Evolving Models of Community-Based Care, takes place on Tuesday, October 20th, so 2 weeks from today. For additional information on all of our thought leadership sessions, you can visit triple-tree.com/Market Insights Live. And then a final thank you to everybody. Appreciate you joining us today, and appreciate all the panelists for joining in this great conversation. Have a great rest of the day. Thanks.